Yeah.
How much can you
Am I audible? Yeah, very audible. Hello. So, thank you very much, Dr. Chauhan sir and PFI for inviting me to do this presentation, and thank you, Yamin and the entire BIA team for inviting me to do this presentation. I'll just try and put the evidence forward, and the science and the evidence has been there for a many years, as Dr. Chauhan sir has already mentioned in the, the genealogy of the development of the molecules. So, with the help of some basic case presentations where we stand, I'll just be reaffirming the faith that one should be having in the particular molecules, and also revisit the scientific evidence from depending on the slides from time to time. And the basic issue is that we talked about simplicity of the management of diabetes, yes, but at the same time we have to look at the optimization also, which has to be there, which I think we can take up during the course of the discussion later. So I'll be going through the presentation through the medium of case presentations, looking at 4 case presentations, basically, and pointer. And basically reaffirming whatever we know in terms of scientific evidence and try to extrapolate that into the clinical scenario, and then it will be up to us to understand and absorb whatever scientific material we have. So we have the first patient, a type 2 diabetic, uncontrolled on metformin, which is pretty much something that we see on a regular basis. It's a hypothetical case, yes, but something to drive the evidence forward. So we are looking at a 46-year-old female, type 2 diabetic for 2 years, postmenopausal, works irregular shifts. Stopped taking glycoside 80 mg recently. Blood pressure and lipid profile at target, no comorbidities, no microvascular complication. Essentially on metformin and atorvastatin. You can see uncontrolled diabetic, normal blood pressure, good BMI, and a good renal function status. LDL is excellent, 50.3. So the basic perception is that linagliptin is not for early type 2 diabetics and restricted to patients with late complicated diabetes. So what does the evidence say? If you are looking at linagliptin as monotherapy or in combination with metformin over a period of time, it is there to stay, for the simple reason scientific evidence has shown that the HbA1c reduction has been supreme in the cases of linagliptin, either used as monotherapy or in combination with metformin or other oral hypoglycemic. So as monotherapy, if we look at a significant reduction in the HbA1c in combination with metformin across the spectrum of a baseline raised HbA1c, you see substantial reduction, and you can see that the higher the level of HbA1c, obviously the reduction is more, because the patient would come down with appropriate sugar control. It also significantly reduces HbA1c in type 2 diabetic patients regardless of the duration of diabetes. So out here you are looking at diabetic in 3 particular segments: more than 1 to 5 years, less than 5 years, more than 5 to less than 10 years, and 10 years. As you can see, compared to placebo, they have shown significant reduction. The linagliptin placebo corrected status reflects that Whatever you are seeing in terms of placebo, if you superpose that on linagliptin reduction, this is what you get. So simplistically speaking, if you are doing an arithmetic calculation, 0.6 plus 0.7 becomes 0.77. Likewise, if the placebo has shown some good effect, it gets reduced. So that's an observation. But over and above that, what it shows that the linagliptin has shown excellent reduction over and above in terms of combination at 6 months of therapy over any level of HbA1c reduction. And the initial combination of linagliptin and metformin shows a 2 to 3-fold increase odds of HbA1c reduction. So if you have a situation of metformin 500 twice a day or metformin 1000 twice a day, if you add linagliptin to it, so from percentage of patients around 23%, it straight away rises to about 35% plus, and likewise you have a similar reduction in a combination of linagliptin 5 with metformin twice daily. So coming up to the second prototype case, again a hypothetical case, but something to drive home the practical points that we are looking at. We have a 55-year-old female returning to the physician after 6 months, which is good because I don't see very many patients coming back even after 2 years. Complains of fatigue and breathlessness on exertion, type 2 diabetic for 10 years. Has been on a DPP-4 inhibitor, not named out here, with metformin 50 plus 1000 BD, atorvastatin, telmisartan. You have uncontrolled diabetes, as you can see out here. Bilateral pedal edema is a clinical sign that is seen. Compromised renal function, 56 ml EGFR as per the CKD EPI calculation denotes stage 3 CKD. So the perception out here that all the gliptins can be used across the spectrum of CKD without any barrier, which is not so. Where do we stand? Let's see. So with linagliptin, it has shown proven safety and effectiveness across the entire spectrum of chronic kidney disease. So whether you are looking at a mild renal impairment or end-stage renal disease with hemodialysis, the amount of HbA1c reduction that you see with linagliptin, along with combination, whether it is oral hypoglycemics or insulin, is almost similar. You can see the range from 0.7 to a 1% reduction, which is significant in such cases. Again, if you are looking at NODAT, new onset diabetes after transplant, it shows a minus 0.8 reduction, and very importantly, in renal transplant patients, it helped to preserve the EGFR after over 1 year. And if we see the EGFR status as per groups described in terms of the GFR, if you divide it into 5 groups, all the groups showed a fantastic reduction of HbA1c over a period of time in a 3-year Japanese study which was done. Though it was a post-marketing surveillance study, but it showed that all the groups starting from a normal GFR to end-stage renal disease, all of them benefited with the use of linagliptin. And albuminuria, as we know, is one of the interrelated disorders of the disease continuum in type 2 diabetes. So once somebody has microalbuminuria, one can be sure he also has a retinopathic problem. He also has a subclinical, if not a clinical, cardiovascular problem, apart from involvements in the other micro and the macrovascular beds. So this is what is seen out here, and unfortunately almost 40% of the type 2 diabetics over a period of time they develop albuminuria. And Carmelina, again a landmark trial which was carried over 2.5 years approximately, showed a long-term kidney safety with linagliptin, a 14% lower risk of progression of albuminuria, and a 15% greater likelihood of significant regression in the urinary albumin-creatinine ratio, and pretty much the good things that you would want to see: increased natriuresis, increased diuresis, decreased hyperfiltration, decreased protein filtration, decreased tubulointerstitial fibrosis, very importantly decreased podocyte loss, which meant that the progression of the end-stage renal disease was kind of slowed down with the help of this molecule. So these were the effects which were seen, and as you can see the microvascular composite outcome, if you see the odds ratio out here, they were all skewed towards the beneficial effects of linagliptin. Now it also improved the glycemic control in patients with or without nephrotic range proteinuria, which is very significant. So if you are looking at the glycemic control in both the groups of patient, it was almost equivalent. This was the adjusted mean change which was seen, and the hypoglycemic events in both the groups were comparable to the placebo effect that was seen overall. So you can see that the figures are almost matching or overlapping. And the new onset diabetes after transplantation, we know that NODAT leads to adverse outcomes, vis-a-vis increased rates of hospitalization, reduced rates of allograft survival and patient survival. But the mean A1C of 0.8% reduction with linagliptin with no hypoglycemic events was shown, vis-a-vis the other modalities of therapy which were there. If you see out here, the A1C reduction was appreciable at around 1% with no hypoglycemia. Yes, understandably with insulin-based regimen, the hypoglycemia was more, and obviously the A1C reduction was more. But you can see with dual OHA, this was almost comparable at a much lower risk of hypoglycemia. The effect of linagliptin on renal progression in type 2 diabetes, if you see this particular tabular representation, you see that this was done to examine the effect of linagliptin on renal disease progression in only insulin dependent type 2 diabetics, which is basically a faulty nomenclature. You're looking at type 2 diabetics who cannot be given any other medication but to be on insulin. They were followed up at 3-month interval for about a year, and eGFR significantly increased in the linagliptin group. As you can see, from around 40 to 42%, which is considered significant from any nephrologist perspective. No significant increase in the insulin dosage, as you can see, from around 45 units to about 47 units, whereas in the insulin only group it went up by almost 8 units. Reduction in the urinary protein creatinine ratio and the uric acid levels were significantly decreased. Now these are all surrogate parameters that a nephrologist would want to see and would be happy about whenever he is treating a patient of end-stage renal disease as a diabetic on multiple therapies and whatever the modality that he is looking at. Also, we need to understand that all the DPP-4s are not equal or equivalent, and an inappropriate renal dose adjustment of DPP-4 inhibitor is associated with a poor clinical outcome. So if you look at all-cause mortality or severe hypoglycemia, if there is inappropriate disease drug adjustment, and in this particular study which was done by Hong et al., almost 40% of the 2 out of 5 patients were on CETA and 1 out of 4 on Vilda. If this thing was inappropriately done, that is, if one was not keeping track of the EGFR. So we know that the other DPP-4 inhibitors, they need to be tapered down as the renal disease progresses. Vis-a-vis the appropriate dosage and the inappropriate dosage, there was a much higher incidence probability of all-cause mortality as well as severe hypoglycemia. So now let's come to the third prototype case, and we are looking at hepatic impairment and linagliptin. How is it placed? So we are looking at a 52-year-old male, type 2 diabetic for 7 years, recently diagnosed with childhood CLD. Shubham is here, so he will help me out with CLD later. Apprehensive in taking injectables, history of dyslipidemia, routine, hypothetical case, so hypothetical medication. We are not looking at additional of other OHs. Glycemic profile, reasonably uncontrolled, 72 kg, but BMI good, and a child Q score of A, which shows compensated liver function. A child Q score of 5 to 8 shows compensated liver function, which basically is the score, the child Turcotte Q score, which shows the deterioration that we are looking at in terms of cirrhosis or hepatocellular carcinoma. So at reasonably preserved renal function. So the perception is that no oral hypoglycemic agents or hypoglycemic agents is safe in chronic hepatic impairment. So linagliptin demonstrates significant A1C reduction in patients with type 2 diabetes and hepatobiliary disorders. If you can see in both the columns out here and both the graphs, compared to the people with no hepatobiliary disorders, the patients with hepatobiliary disorders on linagliptin had an appreciable and almost a similar range in the decrease of HbA1c. And no dose adjustment was required in hepatic impairment, and across all the spectrums of the Child-Pugh score, the amount of fold increase which was seen in terms of exposure relative to normal hepatic function, which basically meant that across the spectrum, whatever dose of linagliptin you wanted to give, there was no need for a dose adjustment required. And as you can see from this particular chart, linagliptin happens to be the only one amongst all the other DPP-4 inhibitors in no dose adjustment is required in mild to moderate hepatic impairment, as well as no dose adjustment required in severe hepatic impairment. So, hepatic failure cases, every which way that you're treating, it depends on the treating physician discretion whether he wants to withdraw linagliptin because the patient may be on a myriad many drugs. Otherwise, he can very well continue with this insulin and the other drugs that may be. And as this chart suggests, it is a highly selective molecule with excretion in the bile with almost 40,000 more selectivity for a DPP-8 inhibition compared to the other molecules, and it is something which is eliminated mostly in bile, so that's why it's considered to be renal safe also. Coming to the last case, classical case of elderly patients who have a risk of hypoglycemia. So this patient had been having the random sugar test which denoted hypoglycemia, metformin, glimepiride, atorvastatin, reasonably controlled, low side BMI that he was having, serum creatinine fairly well maintained, and ECG no abnormalities. So choosing an oral anti-diabetic drug for a higher age group patient is not a challenge. How does linagliptin fit the bill? So if you are looking at, it shows proven efficacy regardless of the patient age. So whichever age category that you are looking at, till more than 75, the rate of HbA1c reduction is appreciable and good, and it shows efficacy across the spectrum regardless of the baseline clinical situation. And it shows proven efficacy in patients with long-standing diabetes, which is defined as diabetes more than 10 years. As you can see out here, compared to the placebo, it showed a significant reduction in the HbA1c, and also across all the levels of HbA1c compared to the placebo, linagliptin showed much better achievement of target of HbA1c in patients who were more than 10 years of duration of diabetes. Remember that in both the Carmelina and the Carolina trials, the significant and landmark trials, the average of patients more than 65 years was almost 57% and almost 50% in the Carolina group. So they were dealing with a huge amount of population which were elderly. And it showed lower risk of time to first occurrence of hypoglycemia if you see the age groups of less than 65 years, 65 to 75 and 75 years. The amount of relative risk reduction with the help of linagliptin is almost equivalent, which gives you the additional confidence about the safety of the drugs, which has a much lower potential of causing hypoglycemia vis-a-vis the other medication that you have in combination. Now, this particular chart shows that across the spectrum compared to the other ones, it has a proven safety in cardiovascular disease, hospitalization for heart failure and chronic kidney disease, with a simple dosing regimen with no requirement for dose adjustment. So, my favorite term for that, fill it, shut it, forget it. You remember the old Hero Honda ad. So once you have given it, you don't have to worry about tapering of the dosage, adjustment of the dosage. It's a single 5 milligram dosage which cuts across the spectrum of all the patients that you are treating, across all the comorbidities, across all the complications that you are looking at. The other things obviously would need to be titrated from time to time depending upon the situation. And now Yamin has given this good news of price reduction of Magenta. So I hope it would be reaffirming your dose and your faith in this. So thank you very much for the patient hearing. All I would like to say is that we have revisited the evidence scientific evidence which has been there for a good number of years for us together, and we should not lose this in the context of new developments or whatever there. Simplicity, as Dr. Chauhan sir said, yes, is the backbone of practice, so that the patient doesn't opt out or doesn't become, lose out on drugs and molecules. So what we are looking at in terms of evidence across, long-standing diabetes, hepatic impairment, renal impairment, elderly patients with risk of hypoglycemia, this pretty much cuts across all the spectrum and is helpful in all clinical scenarios and situations. So this is something that you need to reaffirm in your own minds when you are prescribing. So thank you very much for the patient care.
Thank you, Dr. Sen, for a wonderful presentation and displaying the simplicity of this wonderful molecule, linagliptin, and some well-constructed trials which you demonstrated, and the message, fill it, shut it and forget it. But friends, you would agree that linagliptin is not enough all the times. We need to go beyond linagliptin. We need to optimize our treatment. It's not only about HbA1c, but it's also about achieving good cardiovascular and renal outcomes. Who better than Dr. Viveka sir to optimize linagliptin treatment in type 2 diabetics and to tell us what advantages this optimization with empagliflozin will have in particular. Therefore, I would request all of you to please give attention, keep the noise level to minimum so that you carry home a good message. Dr. Viveka sir has, as I said, come despite having been fasting during the day, and he literally had no snacks here except for liquid diet, which is allowed, of course. Very good. Which is allowed, of course. And I would request Dr. Viveka sir to take us through optimization of linagliptin treatment with combination therapy, especially empagliflozin. What is his experience? He is one of the greatest prescribers of SGLT2 inhibitors along with linagliptin, along with DPP4 inhibitors, and he has great experience, and no better person than him to talk about cardiovascular outcomes of optimizing treatment with empagliflozin. Over to you, sir.
Well, so good evening, friends. At the outset, I would like to thank PFI and the teacher of the PFI who starts with teacher and then ends with teacher. So, if you look at the legacy of what Dr. SenGupta had also shown, is that you need a molecule. Why do you like, as a cardiovascular patient, to always like that the blood sugar variability should be minimum, the risk of hypoglycemia should not be there, and sometimes we see and say that the molecule should be more of an automatic. So, if the hypoglycemia or the blood sugar is high, then it will work as an hypoglycemic agent, and that's the beauty of this SGLT2 inhibitor. But it has also been given in various cardiovascular diseases in non-diabetic patients, especially the heart failure patient, the patient who has got heart failure with preserved ejection fraction or reduced ejection fraction, and also as a good improving the renal outcome in these group of patients. So if we look at the unmet needs in type 2 diabetes, there has been increasing prevalence of type 2 diabetes, and India is a capital of diabetes. So we know that we need to have start these molecules at a much younger age. So our patients are almost 2 decades younger. So we start seeing diabetic patients in the age of early 40s. So that's a sad story of the whole pandemic. If you look at the risk of complication, longer the duration of diabetes, the more the target organ damage and the complication will happen. So South Asian phenotypes predisposes to early microvascular and macrovascular complication, which it means in terms of dollars. If you look at the cost of not treating diabetes properly, the end organ damage would lead to increased cardiovascular disease and heart failure, which will occupy all our beds. and there is a difficulty to achieve and maintain the glycemic target. So initially, as Dr. Chauhan said, that the Brahmastra was the insulin, but I would now disagree with him that the Brahmastra are those weapons which you use without fear of causing collateral damage. So what it will do is it will target the blood sugar, but more importantly, what blood sugar can damage the organs, that organ will get protected. So that is why in real world these the Brahmastra. So what is the real life situation? Only 36% of type 2 diabetes patient will achieve the target of HbA1c less than 7. So, and this is a real world ICMR Indian data which shows that the national cross-sectional study where the various states, I don't know, this is a very busy slide so you may not be able to see it, but definitely the HbA1c level in none of these states is less than 7. So average is not less than 7, and Punjab is a state where the highest HbA1c levels are there on an average for obvious reason because they are foodie. So if you see the patient with type 2 diabetes uncontrolled on metformin, so for many years the metformin was considered to be the safest cardiovascular outcome anti-diabetic medication. So if you look at this index patient, which Dr. SenGupta had also presented, this is again a common garden variety patient which we see 42 years of male having no history of cardiovascular disease in the family, type 2 diabetes 2 years back, no other risk factor of comorbidities. If you look at the BMI, that is okay. If you see the blood pressure, that's fine. But look at the HbA1c, that is 8.5, that is way too high for acceptance. Fasting blood sugar is 162 and postprandial is 210. So let's look at a patient of type 2 diabetes, which is not really controlled on metformin. So this patient was on the metformin. So what do you think are the important aspects of considering before treatment modification? So we need to look at the long life expectancy. So we need to choose the molecules which can increase the longevity of this patient, avoiding the dysglycemic legacy because his HbA1c for quite some time, for almost a couple of years, was 8 plus. We need to also look into the quality of life, and all needs to be considered. It's not that the one factor has to be looked at. So we need to understand the therapeutic and clinical inertia. So what happens that people don't really realize that if you don't control these things well in time, they will have a devastating effect. So HbA1c is something which has to be controlled in these group of patients. So there is a, as a physician, we might say that, okay, the guy will improve his lifestyle, would start walking, doing things, and then in the meantime, we waste almost a year and a half to almost 3 years, and then adding second oral anti-diabetic agents, because the moment you start, the patient says that, no doc, I don't add too many drugs, I'll improve myself, but that doesn't happen. And it takes good long 7 years to start the third add-on therapy, meaning thereby the patient's therapy to keep him in therapeutic zone has got delayed. And what are the effects? Devastating. If you look at the UK retrospective cohort study, which has included more than 100,000 patients, first year delay. So if you have delayed 1 year, what are you doing? The myocardial infarction rates are increasing by 67%. So meaning thereby that we could have prevented these heart attacks if we had upgraded or initiated the addition of second molecule. The stroke rates again whopping for 51% increase is there, and heart failure 64%, meaning thereby the three most crippling diseases the patient had in this inertia of the physician in starting the new add-on drug has resulted into devastating complications and also the healthcare burden on managing these group of patients. So overall cardiovascular event rate has gone up by 62% in 1 year delay itself. So you can imagine that we should not be taking these things lightly. We should act fast, and the moment these things happen, and it's not a mean data, it's not data of less than 1,000 patients, it is 100,000 patient plus data. So it's a very, very impressive data, and we need to work accordingly. So when they initiate a combination therapy, what do the latest guidelines say? So it's not that it's like based on eminence-based medicine or somebody's opinion. It is guideline-based therapy, and it says that whether you look at the ADA guidelines, AACA's guideline, RSSBI guideline, all of them say that the moment it goes beyond the target level of HbA1c that is plus 7%, more than 1.7%. We need to, make it to dual therapy or triple therapy. We should not shy away from, enhancing the molecules, and the safest bet is that add those molecules which do not land you into hypoglycemic complication, because hypoglycemic complication would further increase the cardiovascular and stroke risk. So there are compelling reasons to initiate empagliflozin and linagliptin fixed dose formulation as next line therapy. And in patients with type 2 diabetes, inadequately controlled on metformin, definitely this is the drug of choice. And if you look at the ESC 2019 guideline and onward, we don't have to even choose metformin as the first drug. Those patients who have got high cardiovascular, atherosclerotic cardiovascular disease risk, or the patient has got heart failure of any variety, whether it is HFrEF, mid-range, or heart failure with reserved ejection fraction, the SGLT2 inhibitor would also stand very strong apart from the GLP-1 receptor analog. So we need to choose that. So what happens with SGLT2 and DPP-4 inhibitor have separate but complementary glucose lowering mechanism. So both are pretty safe. So we need to look at the octet with these. So hyperglycemia has to be acted upon from different mechanisms, and that is why the DPP-4 inhibitor and SGLT2 inhibitor are very, very complementary. And then this ominous octet is attacked, and you can have metformin also. So in Western world, we have got combination of metformin, SGLT2 inhibitor, and DPP-4 inhibitor, which is there but not yet in our country, but definitely we can add on as a separate tablet. The possible effect of combination on cardiometabolic risk factors are significantly favorable. So if you see the weight and BP reduction is quite powerful, there is an early efficacy and low risk of hypoglycemia. So that is what Dr. SenGupta meant, that fill it and chuck it and forget it. So meaning thereby that you don't have to really worry about hypoglycemic episode. And what you get in the end is cardiovascular, renal benefit, safety evidence on each individual component, which has been amply shown in last lecture. So along with the reducing the pill burden, improvement in patient compliance also, quality of life also. So he'll feel better because he has to take, before going to office, he needs to just pop in one pill, and his blood sugar, cardiac complication, renal complication, all these things are very, very in control, and that too not by 2 or 4% or manipulation by a statistical analysis, but it is whopping 50%, and that is quite impressive. So that is what we need to do. So early achievement of goal and durability of action is something where, in the background we are working with metformin, but when you add on linagliptin, empagliflozin, you can see that these effects not only start pretty early, but they are very much sustained for a long period of time. This is more than 5 years data. So definitely this is something to look forward. And early achievement and goal durability of the action. So, see, you want that the effect should start right away and should sustain. So there is no place for tachyphylaxis and kind of things that. So if you look at the further data taken into this, that further HbA1 reduction in patient with baseline, like in our index patient of HbA1c of 8.5%, you can see that the mean change from the baseline HbA1c by adding just this combination has resulted into nearly 2% decrease in HbA1c. So that's again, and without the added risk of hypoglycemia, and plus giving the good effect on the target organs, that is heart, renal, and the stroke outcomes. So percentage of the patient who achieved HbA1c, which we say that it's a very good achievement. If HbA1c is less than 7% at 24 weeks, you can see that in drug-naive patient also, and the patient who are on metformin also, and with the combination of these two molecules, AMPA and LINA, you can clearly see that the patient come into target zone. So again, if you see the other garden variety patient which we see, and this is more specific to our country, where 38-year-old obese male had recent diagnosis 6 months back, diagnosed with diabetes. There was no family history of cardiovascular disease, non-smoker, but his BMI was slightly on the higher side, blood pressure borderline, HbA1c is 7.7, and the fasting blood sugar was 134, BP was 200, and so in this you can see the patient has the HOMA B is 150 and HOMA IR is 3.6. So if you see the current therapy of this patient, he was on the glimepiride 1 milligram twice a day and metformin 1000 milligram once a day. obviously he had to add healthy lifestyle, and so this is what we see in our common garden variety of current generation of the patients who are working in multinational. Desk job is there, they have to do a lot of doing and all, diet is not healthy, so there the target organ damage happens more. So what happens, there is a weight gain and insulin resistance is there in these patients, there is a declining beta cell function, hypoglycemic risk, and all these factors has to be taken into account when we are treating these group of patients. So expert opinion for appropriate use of SGLT2 inhibitor plus DPP4 combination in type 2 diabetes without causing hypoglycemia and promoting the weight loss is something where you do achieve weight loss and adequate control of the sugar is by the SGLT2 inhibitor, and with the DPP4 inhibitor, which is a weight neutral, but it will act very strong on the sugar. So you get a good sugar control and also without fearing the hypoglycemic risk. So optimization of the EMPA-LINA fixed dose combination is something which is very important, because the patient will have weight reduction, and by virtue of reducing the weight and diuretic effect, there is a blood pressure reduction also. You can see quite significant blood pressure reduction is also there, and also the added advantage, which is very common in our part of the world, where this uric acid is high, so this will work on the uric acid also, so that the effect of uric acid is also controlled. So you will be surprised to know that there are many patients who had blood sugar very totally uncontrolled. They were on very high dose of insulin and all, but it was ignored that this uric acid was high, and once you control the uric acid, all the anti-diabetic medication dose has to be decreased. So controlling uric acid is also a very, very important step in controlling the hyperglycemia. So we need to optimize the fixed dose combination of EMPA and LINA. So we can start either with 10 milligram and 5 milligram combination, or 25 milligram of EMPA and 5 milligram of linagliptin, or we can give the separate tablets also, so the compliance may not be as good as it would be with this. So optimizing this fixed dose combination would do wonders in these group of patients. So this is far more better than just giving linagliptin alone. So that is what we meant, that early optimization and fixed dose combination is something which is really, really good. So in our reference cases, early and robust up to 1.8% HbA1c reduction from the baseline of more than 8.5% is something which is desirable and which can easily be achieved with this combination. There is a significant weight and blood pressure reduction also. There is a minimum risk of hypoglycemia and low risk of genital infection, because remember, if you give the SGLT2 inhibitor alone, the risk of genital infections are significantly higher compared to when you combine it with the linagliptin. But is that enough? The answer is not yet. If you look at the other benefits you get, 3-point MACE reduction is significantly better, and that is what Dr. Chauhan meant, that the all stories started with EMPA-REG outcome data, and then complemented with Carmelina data. That 3P MACE comes down, cardiovascular death comes down, the heart failure hospitalization comes down, and the kidney outcome, which is a strong contributor for adverse events, is also quite favorably affected. So definitely both Emperor Preserved and Emperor Reduced have shown that no matter what variety of heart failure is, if you add empagliflozin, you stand to gain in outcome. And remember, the preserved ejection fraction heart failure is very difficult entity to treat. We did not have any other molecule except for some benefit with the MRA antagonist, but none other than this. There was no molecule. Even ARNI failed in this group to have statistically significant benefit. But this is a molecule which really has in that. And remember that a lot of diabetic patients who have got preserved ejection fraction, but because of the unfavorable relaxation property of the heart, they go into diastolic heart failure. So we can easily add SGLT2 inhibitor and get the benefit. So empagliflozin, if you look at the EMPA kidney trial, a lot of patients would have cardiorenal syndrome. So there also the relative risk reduction is almost 28%. So if you look at the event rate reduction is significant, 28%, and number needed to treat is also very low, just 28. So if you see the combination benefit of the two is humongous. So you can have combination of EMPA and LINA. You will have lesser chances of urinary tract infection, minimal risk of hypoglycemia, and complementary mode of action of these two molecules. And that is why but you can't generalize this. When you look at the benefits, given by other similar combinations like hemoglobin and Vilda, that's not, significant enough to write all the boxes, tick the right boxes, or DAPA vildagliptin also does not have the similar power to benefit in these situations. So definitely the combination conundrum is that we cannot compare the benefit we get with EMPA-LINA combination. The similar benefit is not there with even sitagliptin and dapagliflozin fixed dose combination. So that is why we need to choose the combination molecules much careful, and I think these slides have also been shown by Dr. SenGupta also, that hepatic renal impairment, albuminuria benefit, all these things are there when you combine these molecules, and they have got this benefit also separately as well. So cardiovascular outcome evidence with these molecules has been shown, and that is why it has been approved in India. So you can see this is a molecule where when you combine EMPA and the linagliptin, there is a three-base reduction of 14%, cardiovascular death reduction by 38%, hospitalization due to heart failure is 35%, and renal outcome gets improved by 46%. So meaning thereby that you have this is the best molecule for improving the cardiovascular outcome data. So the EMPA and Lina proves risk of risk modification at every stage of continuum. So whatever the hypertension issues are there in patients who are obese and diabetic, this is a combination which will help also for the myocardial infarction and heart failure. The micro and macrovascular complications are taken care of, and also the end stage renal disease delaying happens with this because of the beneficial effect on cardiocerebral vascular deaths are also lesser, end stage heart disease is also lesser. So eventually you have to have all the end organs, they get protected because of this. So contraindications for this combination, which is commercially known as Glixambi, is not recommended in patients who have got EGFR less than 30, though with the recent evidences the envelope is getting pushed, and that is what Dr. Chauhan meant, that probably now end-stage renal failure patient also, once we get the data, probably we will be using it more often. So thank you very much for your kind attention. And
friends, I think we had a wonderful discussion on two molecules. Sir, please be seated here, sir. Maybe light jala deenge. So we had wonderful discussion on linagliptin and empagliflozin, optimization of linagliptin with empagliflozin. First, some very important message. Some of our friends are going without dinner because the question answer session goes on and on. And Dr. Jasbir and his daughter, they are continuously going without dinner. Sir, just give us 15 minutes. I assure you, exactly at 10:15 we will open the dinner. You can have your dinner even if the question answer goes on. Okay? So, we'll start with the question answer. Dr. P.K. Mangla sir has been with us right since the inception of forum. He is a very, very keen physician who takes interest in diabetes. One of the best pulmonologists in town. Sir has a question to ask. I know he is very fond of writing linagliptin himself and has been writing empagliflozin off and on when indicated. He used linagliptin tremendously during COVID times. Sir, I would request you to ask your questions.
My question is to first Dr. Viveka Kumar. So actually, in my practice, indoor patients, COPD patients, most of them are diabetic, hypertensive, hypothyroid. These patients come at times with clear-cut COPD, asthma. At times, they are breathless, and you feel that it is not primarily the COPD or asthma which is making them breathless. And you do their CT, they have bilateral effusions, anti-proBNP is high, and we label them as diastolic heart failure. I would like to ask you, when we send this referral to the cardiologist, they write dapagliflozin. Certainly if the patient is not diabetic, they are still writing dapagliflozin, and they give a damn to the UTI or thing, and this prescription is written. What kind of a doses of diuretics you give to these patients, and what is your prescription for these patients?
Yes, I think that's a very good question. And if you see the diastolic heart failure, that is something which is not being, yet conquered, I would say. But after the inception of, once we have the data from, infrared preserved and then the data from delivered with the data representation and all, now we have enough evidence that we can decrease the adverse outcome and the symptoms of these patients, and even mortality can come down when you add on these. So definitely, by taking precautions to decrease the UTI and all, we would take care of the at least the mortality part will be taken care of. The second thing is that we can, the other molecule which is very, very important in this setting is the MRA antagonist. So if we add, spironolactone, or we can add the eplerenone. Now we have got pregnenolone available, so we can use pregnenolone also. And these outcomes will be much favorably affected. And remember, these all heart failure, whether it is preserved or reducing ejection fraction, the diuretic has an important role to play. So fluid overload will come down when we use. So we use usually 10 milligrams of torsemide in these patients because that's a slightly longer acting. So apart from, but you can use furosemide also 20 milligrams once a day. But obviously the need for high or intensive dialysis is not justified in diastolic heart failure. There has to be what we call mild, so the 10 milligram of torsemide or 20 to 40 milligram of furosemide would be good enough in this situation. The second thing is that we sometimes, though there is not mortality benefit, but symptoms benefit in these patients is also for diastolic relaxation is much better when we control the heart rate, so we can give ivermectin, and also the calcium channel blocker diltiazem or verapamil would also help in these group of patients. So I think patients who are going from pulmonology, so these patients till the understanding of diastolic heart failure became better, they were just labeled as they are not either. So nobody was the caretaker of these patients. Pulmonologists would say that look, in your echocardiogram is showing type stage 2 diastolic dysfunction, so you go to cardiologist because nobody knew that how to treat these patients. But combination of these 3-4 molecules has made their life easier, and I think this is the way to go about.
Some patients, they have a raised creatinine of say 1.4, 1.5, 1.3. Adding these MRAs, and if these patients are hypertensive, they are already on Telma kind of a drug. So how justified are we? And second thing is, if the echocardiography report, the cardiologist or the echocardiologist writes IVC 21, are you justified in giving them 40 milligram TDS of Lasix or furosemide, and how long to give? Or you should just give them MRA or Ditor plus kind of a stuff. How severely the diuretics should be given? Because at times they will write 40 milligram TDS and then you give them call again, or every time you do a echo and see the IVC status and then monitor diuretics. It's a tricky situation.
Yes, I think remember that there are two types of molecules. One is that to improve the symptoms of the patient. The other one is to improving the mortality, and the outcome data will be better with them. So diuretic at best is for symptoms only. So I would say that start with obviously you can start with the lower dose and then up the dose. So I would not agree to start 40 milligrams thrice a day. In ICU setting you can give intravenous 20 milligrams thrice a day and then try to dehydrate. And once the IVC is collapsing with the respiratory things are there, then probably you can make it oral tablet once a day at 20 milligrams, and most of the patients would settle down on that. Unless also the important thing which we need to look at, that we have got a lot of great understanding now with the cardiac MRI availability, that there are a lot of patients who have got infiltrative cardiomyopathy. We have seen, once we have got pyrophosphate nuclear study available in our part, then we have been seeing a lot of patients of amyloidosis, sarcoidosis and all those things which were underdiagnosed, and they were not diagnosed because the echocardiographer was not really looking for that. So these infiltrative diseases are also pretty common, and that has also to be. So once the oncology has come up, as a very, very robust branch, we have seen that the pickup rate of these syndromes are also high. So quite a number of diastolic heart failure patients would be infiltrative diseases also, and that also has to be looked at. Just the diastolic dysfunction is not good now.
Okay. So SGLT2 and MRAs should be added to all these patients?
Yes, I would say that SGLT2, MRAs, and if you suspect concentrated disease. So control because you need to give heart rate enough time for diastolic filling. So I would say that increasing the diastolic time by controlling the heart rate is also very important. And remember, these patients, if they are not in sinus rhythm, they will be heavily symptomatic like hypertrophic cardiomyopathy. So make sure that they are in sinus. Some of them would have, as you will be seeing, that they would have some pulmonary disease also, and the diastolic heart failure also. They would have multifocal atrial ectopics and all, and that will also lead to some volume overload because the atrial kick has gone. So that sinus rhythm has to be maintained at any cost in these patients.
Beta blockers have no role.
Beta blockers have not shown to improve beyond. In fact, the hospitalization rates go higher in these patients.
Thank you.
Sir, Dr. Shubham was an eminent gastroenterologist and a very important member of the forum. He has a question. I know, I have seen his prescriptions. He uses empagliflozin a lot in his patients because he comes across a lot of diabetics, type 2 diabetes, gastroparesis, reflux disease, hiatus hernia, and I have seen his prescriptions of empagliflozin. Your question, Dr. Chauhan.
So I would ask you that we have a lot of patients with non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. Classical teaching tells us that it's insulin resistance which causes this. It's not a liver disease. So we use empagliflozin. We have studies. We have the Flint trial. We have the Resolve It trial. We have multiple trials with discussing use of pharmacological agents on insulin resistance to improve dyslipidemia and NASH. So the most common cause of death in NASH, according to HOMA IR study, is MI, myocardial infarction. So it is not a liver disease as such, it is a PCOD of the liver basically. So what is the in your experience with the use of SGLT2 inhibitors, the drop in insulin resistance? Yes, in NASH there is a bias because SGLT2 inhibitor will cause a little bit of weight loss, so the liver function will increase. But is there a genuine improvement at the level of insulin resistance which is at fault, which is causing NASH and MI basically?
Yeah, so I think that's again a very good question. If you look at that's a big problem in our part of the world where the patients are diabetic also would have the dietary pattern which is very rich in the carbohydrate intake. So NASH is very common, and if you look at the recommendation, SGLT2 inhibitor has come as a class 1 drug for being used in this group of NASH patients, and also apart from saroglitazone, it is again has come.
I was about to come to that. So what is your experience with PPAR delta drugs which are saroglitazone, which we use prolifically?
Yeah, so I think we have been seeing that this is something which is a revolutionary molecule as far as the NASH is concerned. So these two molecules have really changed the whole scenario, and we have seen that fibroscan and all has become so, the patient had gone into depression that now he is on the path for liver transplant, and they have completely transformed the NASH things. I would say that this fatty liver and all, if you combine these two drugs in these group of patients, the results are wonderful.
So you took that thing away. Saroglitazone is a wonder.
Yeah. Dr. Narendra Singh has a question, sir.
So, this one, Shubham, how often do you advise calorie restriction in the diet for such a patient?
So it is definitely advised. The main problem is that we are a carbohydrate-rich population. The problem is that the glycemic index of the normal staple diet we have is so high that the insulin spike postprandial is so high that it's very tough for these patients to actually restrict the amount of calories. So if we just ask them, if I ask a patient to just take away sugar from his tea or coffee, he's surprised and he thinks that I've asked for his kidneys. So, and if it is, he's developing NASH and the fibroscan is around 8 or 9 with NASH, I'm telling him you need to keep your salt low as well. So he says no salt, no sugar. So that's a big problem. The compliance is an issue. As they say, multiple studies say that even if they lose weight, you come back to 2 to 3 years, or when they start, they are at baseline. Looking forward to Mukesh Ambani's son, all of us know, he lost a lot of weight, but 3 years down the line, he's again 150 to 160 kgs. So that's the problem with our country. That is why these drugs are coming so fast. So that actual weight loss is so tough.
Exactly. So let me just seminal banding lecture about the adiposity of the development of diabetes is when he talked about caloric excess. So whether you are talking about NASH or the spillover of VLDL into the islet cell circulation, until unless the caloric excess is restricted, by and large, apart from medicines, whatever we are giving, nothing is going to happen. That is, and it's very difficult.
So class 1 recommendation, weight loss.
Yes.
Weight loss, weight loss. The only two other things which have class 1 recommendation is black coffee 3 to 6 cups without sugar.
Absolutely.
And maybe vitamin E 400 milligram BD.
Yes.
Other than that, pioglitazone is off the table. Saroglitazar has some data. Empagliflozin is again diabetic dyslipidemia, diabetic insulin resistance.
Absolutely. Too much of vitamin E also can cause a cardiovascular problem.
Dr. Narendra Singh has a question.
Dr. SenGupta, only one question. In microal, if a patient has got microalbuminuria,
Yes, sir.
can we give linagliptin?
Absolutely.
Okay.
Absolutely.
And another question, another one, empagliflozin, if a patient has got high anti-proBNP, and high, is a patient of CHF, even if he is not diabetic, can
We
we
recommend it, sir.
We can recommend?
Diabetic or non-diabetic, heart failure, reserve ejection fraction, mid-range ejection fraction and reduced ejection fraction, it is recommended. What is perceived right now, as Sir said, maybe in reduced ejection fraction or diastolic heart failure, it may come in the recommendation, but I don't think right now it is there. Empagliflozin in reduced preserved ejection fraction, it is now there.
Thank you, sir.
Dr. Kanturu sir has a question.
So as linagliptin is concerned, there is no renal problem. We can give it because metabolism through the atherohepatic circulation and it goes out. But about EMPA, so what should be the level of the serum creatinine? And we are giving it in a combined dose so that the kidney effect is not there.
So if you look at the guideline that says that eGFR of 30 is recommended. Now we have extended it up to 15 also, but definitely the 30 is as of the guidelines says.
And what should be the EMPA dose? Because there is a 10 milligram, 25 milligram.
No, so lower you can give it in 25 milligrams.
Dr. Amitabh sir has a question. Dr. Amitabh Gupta, please.
Dr. Viveka, I enjoyed your session. The only thing is semaglutide, what is the drug? And I had one of my patients and it was advised by the endocrinologist to take this drug to reduce the weight. He was like over 200 kgs and we operated on the spine. The problem was the weight reduction. The main issue was the weight reduction and the patient could not have that. So what is this semaglutide drugs and how much weight can be reduced by this drug in this particular patient if we advise them?
Yes, I think that has got an FDA approval for standalone weight reduction is there. So it would, on an average, there is a 5 to 10 kilograms of weight reduction over a year's time is there. So definitely it's a very, very powerful agent. And now in these, obese patients, the recommendation is that you go full throttle, so you can combine SGLT2 inhibitor and because now you have got availability of oral semaglutide also, so you can give both together and that will be the wonder drug for reducing the weight. Dr. SenGupta wants to see that.
So this falls under the category of GLP-1 receptor agonist. A further development on liraglutide, and it has undergone extensively pioneered 1 to 8 trial programs in which it has been titrated even against liraglutide, plus oral hypoglycemics, insulin and multiple case scenarios, plus Indian individuals also, shown to have excellent weight loss. Yes, the initial problem of, there's a titration phase in which the first month you give 3 milligram and then we see whatever the side effects are and then you up titrate it to 7 milligrams, second month onwards. This is now, earlier internationally available as Wegovy, as the injectable once weekly thing. Right now, and worldwide available as Ozempic, as the drug, oral drug. In India, as Ribelsis, 3 milligrams, 7 milligrams, 14 milligrams. And it has excellent weight loss capacity.
But as I understood by Dr. Viveka, he is saying that 5 to 10 kilograms a year, if I am right. So probably this guy will anyway need to have it, some kind of a bariatric surgery or something kind of a other thing to look after, because this drug will.
No, so I think if you look at the whole story of obesity, these molecules have, because these people who have got BMI of 35 plus, they have lost hope that they will never lose their weight. So this works as a very strong kick for lifestyle modification. So using 10 kilograms makes them motivated, and obviously is a lifestyle disorder. So once you do that, it adds on year after year. It's not that you need to stop it, you can continue taking it for a long time.
This is not a substitute for lifestyle modification. That supplemented with this has to continue.
I agree, because I was told that probably, I was told by my endocrinologist by 20 to 25. So probably that is a little bit over.
No, right? Over 3 years of time, it will be 25.
It may.
So it's over a period of time, but every year it is 5 to 10
There is
years.
a sustained benefit.
Dr. Amitabh, thank you very much for questions. Dr. S Singh has a question.
Thank you, sir. So today we have discussed diabetes, renal impairments, cardiology, and other associated problems. My question is to the patient, HIV patient, having diabetes, having renal impairment, having hepatitis C. We manage this patient in relation to the cardiology, renal impairment, and other problems. How this patient will be treated?
Yes, I think now HIV has lost its sting as much as it was before. So it is now you have to treat them as a regular patient. So you have to give all the class of drugs which improves the overall outcome. Obviously, the HIV, the retroviral treatment and all that will continue. The paradox was that in Europe, people felt that there was so much of budget allocated to the HIV positive patient, and it was felt that probably they will not survive for more than a year or so, but they survived, outlived everything, and now they are doing absolutely fine. So the burden of these patients has become really high. So now there is enough data that they should be treated for other diseases, same as the general population. So if they have got diabetes, you treat the best in class drug. If they have got renal impairment, you need to adhere to the same guidelines to preserve the target organs.
My second question, sir.
Okay, I think we'll go to Dr. Tulsi straight away now.
Thank you, Dr. Chauhan. So those two masters, Dr. SenGupta, an eminent cardiologist, and Dr. Viveka, our favorite cardiologist. So, to Dr. SenGupta, just 2 minutes, sir, just 2 questions, small questions. Diabetics have augmented atherosclerosis or ASVD. So it's important to start drugs which have cardiovascular benefits. Does Lina have any cardiovascular benefit? We know it has renal benefits. Does this drug have any cardiovascular benefits?
It's been found to be cardiovascular safe,
neutral.
Cardiovascular neutral in terms of effects. So no cardiovascular benefits per se. That's the domain of empire and the others.
My second question, Dr. SenGupta, would be DP4 inhibitors are associated with no added risk of major cardiac arrhythmias, but atrial flutter to the tune of increased 54%. Patients who were on SGLT2 inhibitors, on DP4 inhibitors had atrial flutters. So how do you explain this? So this is not what I am saying. This is a large RCT6, let me complete. Large RCT, 6 RCTs involving 55,000 patients. We said this drug causes increased incidence of atrial flutter. How do you explain that, sir?
So these could be, basically things limited to the particular patients. How it's not been defined. Like sitagliptin in the TCOS study was found to be cardiovascular safe totally. Linagliptin cardiovascular neutral. But in terms of irregularity, you always constantly have to monitor the patients for any additional thing. Now whether that per se has been because of linagliptin, I am not very sure, but if it has been there, obviously it has to be treated. And if this is being taken as promulgated as one of the putative factors, obviously taken out of the equation.
Right. So, to Dr. Vivek, okay.
Yes, I think if you see, there is no LA volume reduction with D2 inhibitors, so the volume index goes high. So cardiovascular volume index, LV end-diastolic volume, and LA end-diastolic volume. So the stretching effect, if you look at the SAVO trial and all there, the heart failure, hospitalization rates were higher with the DPP-4 inhibitor compared to the non-DPP-4 inhibitor. So the stretching effect on the heart will cause increased incidence of atrial flutter and fibrillation, because we know that whatever the cause is, even in heart failure, the patient's non-rheumatic or other causes, plain heart failure where the volume overload is, the cardiac arrhythmias are significantly higher. So probably that would be the reason. When you combine it with, that is why the importance of combination therapy is there. So when you combine with the SGLT2 inhibitor, the volume goes down and the risk of cardiac arrhythmia becomes less.
Wonderful.
So the Salvatini trial had this kind of a signal for S SenGupta, for which it has not been used after that.
So, Dr. Viveka, now the latest trial on JAK published last year in June 2022, SGLT2 inhibitors and acute MI. See, the 3 trials, one is the ME trial which was published last year, the 2 ongoing trials, the IMPACT MI and the DEPA MI trials are to be published probably next year. So, you being such a reputed cardiologist, do you really prescribe SGLT2 inhibitors in acute MIs right from the beginning? Considering we know that these drugs cause hypovolemia, these drugs cause hypotension, these drugs cause ketoacidosis, diabetic ketoacidosis, these drugs cause AKIs. And with increased use of angiography and incidence of CIN also is there. So would you say probably it's prudent to be safe here than to give these drugs right from the beginning? Or have you started using SGLT2 inhibitors right from the beginning in acute MI, sir? Please.
Yes, I think we do not use before the revascularization. Either we have done the primary PCI, so the patient had Minoca where we automatically decriminalize coronary artery is there. And obviously the benefit is more in patients who have got at least moderate LV dysfunction. So we don't want, as you rightly said, that we should try and avoid using acute ICU setting, which we call acute decompensated heart failure. Though the data is that we can use it, but we need to select our patients very carefully. So obviously there are very few settings in acute decompensated heart failure where you are not able to get ACE inhibitor because the low blood pressure, you cannot, volume overload is there. So in those situations only, but otherwise it is ketoacidosis.
You are talking about volume overload, sir?
No, in acute heart failure, post-MI situation. Post-MI situation. So post-acute MI, only indications will be where LV dysfunction is there, but it is off-label use. You cannot really use it in ICU setting and post-MI setting, so we still not started using it.
We are awaiting the 2 large trials.
In fact, if you see the experience there, we try and take the patient off if they are on SGLT2 inhibitor, and if they have an acute myocardial we try to hold it on and put them on sliding scale of insulin rather than continuing the SGLT2.
So this is what I wanted to know. Why would you stop SGLT2 inhibitors in acute MIs?
No, so that is why the patient...
You remember the embody trial, which said that these are the drugs which can be given to reduce the sympathetic overactivity and thereby reduce the arrhythmias, especially the malignant ventricular arrhythmias.
No, so what I meant was that those patients who are, so that is what to begin with, I said that the patient has to be stable enough. So the patient who are stabilized, so when I said that the patient who has been revascularized either by thrombolysis or primary PCI, then you are justified to, because otherwise these are the patients who can behave either way. So the discussion is that we should be using it only in stable post-MI patient, not in unstable.
Thank you, sir.
We need to wind up with Dr. M. Kalra, sir.
Sir, after such a educative lecture by 2 stalwarts, very two small questions, sir. First to Dr. SenGupta. Sir, as you mentioned about new onset diabetes after transplant. So you spoken on linagliptin. What about this combination, EMPA plus lina, in such patients?
New onset transplants, multiple combination, lina, two-drug combination, three-drug combination with insulin. Basically, you try out combination as for the control of diabetes as the case may be for different situations. So you can empagliflozin once the GFR is good. So that's it.
Dr. Viveka sir, about Dr. Sushil's very new educative comment about 54% flutter. Honestly, I've never seen a flutter in such patients. I don't know whether they complain, how it was found, and how we come across, maybe in some studies. But it's not adding to any of the outcomes because it's a benign thing. And because it is, well, I would say, is it
marker for increased incidence of strokes, MIs, heart failure, and all-cause mortality.
Outcome in all the studies has been they are neutral. They have not been found to be cardiac as a red flag. Sir, my point is, EMPA and lina, if we were together, I think flutter will be very much reduced if it is based on the volume of the left atrium.
Yeah, but right. So that is why this combination is so lucrative.
This combination will be much better. And what about if we give EMPA in a patient of no diabetes, only for heart failure? The chances of genital urinary infection will be much less versus a patient of diabetes. This is my
so I think that's right that the combination would have significantly lesser genital urinary infection, and myth of not giving SGLT2 inhibitor in heart failure patient, those who are non-diabetic, is totally busted. You can give it whether it is preserved ejection fraction non-diabetic, reduced ejection fraction non-diabetic. In all of them, the hospitalization due to heart failure is decreased by 42%. So this is something which has to be given, and that is why we need that SGLT2 inhibitor is an automatic anti-diabetic agent. If the blood sugar is high, it will decrease the blood sugar. If it is not high, it will not decrease it.
Sir, I think with permission from Dr.
Just one small. I mean, what you mentioned theoretically is absolutely fine. But I don't know how many of us have actually seen atrial flutter with so much of our experience with Trajanta and empagliflozin or Trajanta or Bilda or sitagliptin. I think we are using it right, left and center. Very many patients don't even come back for a required 15 days, 2 months, 3 months, 6 months, even a year, and they continue to take it. I mean, and they do very well. So I don't know how much of that is applicable to the Indian patients, and the trials that you mentioned, sir, very rightfully. I don't know how many Indian patients were there, so I don't know whether there's something to do with genetics or with our practical observations and practical things that we're looking at. So, I mean, I would be very reserved. I mean, theoretically you stand, theoretically whatever you said about the LA volume, absolutely fine. But practically I don't know how many of us have actually seen atrial flutter. At least last 4 years I have not seen a single atrial flutter. What he is talking about is paroxysmal and occasional peak on the
This was published in World Congress of Cardiology and involving 55,000 patients. This is not what I am saying, this is what I am saying.
I'm not denying that.
Thank you, sir.
I'm not denying that at all.